Good morning. Welcome back. You're watching Daybreak on Citizen Television, and thank you for staying with us. Zooming in on the healthcare plan in the country and what the government has in terms of the pathway to universal healthcare coverage and the burden of cancer in the country. The prevalence per counties here, and Bungoma leads with 1.5% in terms of the prevalence, followed by Vihiga County at 1.3%, Taita Taveta 1.2%, Homa Bay County 1%, Trans Nzoia 0.9%, Nyamira and Narok 0.8% and 0.66% in terms of the counties as ranked by the agencies in the country. Migori at 0.5%, the county of Tana River at 0.3%, so is Marsabit and Wajir, while Mandera at 0.2% and Lamu and Samburu are at 0.1%. In terms of the prevalence. Among men, these are the leading types of cancer: prostate at 23.7%, esophagus at 15.9%, stomach at 8.7%, mouth and oropharynx at 7%, liver 3.6%, and bone marrow at 3.4%. Also, the distribution among women: breast cancer leads the way with 26.5%, cervix uterine at 23.2%, esophagus at 8.8%, colon and rectum at 5.8%, and mouth and oropharynx at 3.7%. Now, this is also the prevalence among children as detailed by the still on continuity among women: stomach at 3.7%, corpus luteum at 2.7%, ovary at 2.7%, and bone marrow at 2.4%. Among children, leukemia leads the way: kidney, brain, lymphoma, and nasopharynx at 7%, which is ranked the last according to this report. In terms of the prevalence as per the death percent, esophagus leads with 15.6%, cervix uterine at 10.4%, breast cancer at 9.6%, liver at 9.1%, leukemia 8.5%, prostate and stomach cancer 7.8% and 7.2% respectively. Now, President William Ruto, then of course Deputy President, when he launched his manifesto on the 30th of June, had this pledge for the country, and that he is committed to the people of Kenya that we will have universal health insurance that will enable every Kenyan to seek treatment in a hospital or hospitals and walk away without paying a penny. That was a pledge made by the president. The interesting bit about this is that the healthcare country in the country, according to World Health Organization, 40% of our graduate doctors normally flock out of the country in search for better pay because of the conditions here in the country, which is a burden on the healthcare system because of the growing population and the lack of doctors who will attend to the very same people that the president has pledged will better the healthcare system. This financial year is when the healthcare system in the country was allocated the biggest, 146.8 billion Kenya shillings. But that is just 6% of the gross domestic product, GDP, which is 9% below what was agreed under the Abuja Declaration in Nigeria, which is still below the target of the declaration made in Abuja in Nigeria, which means there's still a gap of 9% that needs to be filled by the government to meet the commitment as per the signings made by the government. Now, last year had the highest number of registered doctors according to the Kenya Medical Practitioners and Dentists Board, saying the registration of 1,330 doctors. The year 2021, 955. In 2020, at the height of the pandemic, 1,321. In 2019, we had 767. In 2018, 979. That totals up to 5,352 doctors. Of this number, only 1,000 have been employed, which then means that 4,352 doctors are unemployed in the country. Then makes the case of the 40% who are flocking out of the country in search of employment elsewhere. And Kenya is a country that depends on its human resource in terms of growing its economy. According to the Kenya Medical and Practitioners and Dentists Board, the required doctor-to-patient ratio as per the World Health Organization recommendation is 1 to 1,000. But in Kenya currently, as the situation or the status quo stands, it's 1 doctor to 17,000 patients, which then means that the hospitals and the doctors will be inundated and overwhelmed because of the sick people who visit healthcare centers in the country and how to further better the primary healthcare model and system in the country. And it's on that note, then we take the account of the Secretary General of the Kenya Medical Practitioners and Dentists Union in the country, and as well the deputy chairperson of the Parliamentary Health Committee in the National Assembly, who as well is the Chuka Igamba Member of Parliament, Patrick Munene. And now I hand it over to my colleague, Safin.
All right. Thank you so much, Ayub, for taking us through the numbers, of course, drawn from a report by the National Cancer Institute of Kenya that was released last week, dubbed the Status of Cancer in Kenya, a report that captures the year 2023 to 2022 to 2023, of course, ranking Nairobi, Nakuru, Kiambu, Machakos, and Nyeri as among the top 5 counties in cancer cases in the country. Ayub has taken us through some of the percentages in terms of counties and the cancer cases across the counties there. And like he has rightfully said, we have in studio a panel that will be putting some of these numbers into perspective, including even the status of the general healthcare system in the country, because we rely on our human resource in the healthcare system to be able to implement some of the issues that we want done to assure Kenyans of quality healthcare service. So just a quick one to rope in our guest in studio this morning. Like we told you, we are hosting Honorable Patrick Munene, the Member of Parliament for Chuka Igamba. He also is the Deputy Chairperson of the Health Committee in the National Assembly. Thank you, Mheshimiwa, for creating time. And we have in studio Davji Himji, is the Secretary General, the Kenya Medical Practitioners and Dentist Union. And of course, thank you so much for creating time for us as well.
Thank you.
All right, so we just want to, ask you a general point in terms of the numbers that we have just been taken through, SecGen. This is the very first time we are having such data that captures the counties and the country in terms of the cancer cases. All along, what we've been doing is to use numbers and estimates from Globocan. Probably tell us a bit about what these numbers mean for you and how they are going to impact our interventions when it comes to addressing the cancer crisis.
Thank you so much. I think the fact that we can now have statistics for cancer burden and actually to specify different cancers and give out that overview based on the regions is a good step for the country. But if we can see clearly that in the last 10 years, the last 1 decade, there's been an increased incidence of about 29% as per the report that is indicated. That means before there were about 37,000 per year, and now we're talking about 48,000 cases every year. And one thing that comes out clearly that these are just families that have somebody that has been infected by a particular type of cancer. So as we give this data, there needs to be a clear plan that the government is putting in place to have management of these cancers. One thing that has come out clearly, and what brings out this matter, is that many families, over 1 million families, go to below poverty lines because of the cost of care of cancer. And many times, the management of cancers are concentrated in the urban regions, in the towns. So many of the families that come in the rural areas, they will not actually know that they have cancers for a long time until when they're in the late stages. And these has to be referrals to either level 3 or level 4, level 5s or level 6 referral facilities in the country. This is because we do not have a clear infrastructure that gives the diagnosis that manages these cancers as needed. And that's one gap that has been seen. Number 2, the increase that we see currently also is attributed because of there's been more awareness lately on the cancers. So many people actually there's a bit more screening, annual screening of cervical cancers. There are more tests that is being done. So that means the numbers are increasing, that are being seen. But one of the statistics that I was seeing was indicating that even in the next 1 or 2 decades, the incidences will actually increase to 120%, because therefore the awareness will be much more, will be to the people. The other thing that needs to be really looked into is how is the management. Many families that actually have the cancer, that have the patient, realize that they struggle to have the patients managed. And about 80% of Kenyans don't have any insurance cover. So they end up having either community contributions that the community are contributing, and some also have to actually forgo the treatments because they can't afford the costs. You realize that the NHIF has up to a given level of therapy that you have to be managed. Okay. The point that they now leave you with that burden. And I think that also will contribute to the significant numbers of the cases that we see. But some of these cancers actually, if there's a very good strategy in the country, they can actually be prevented. Things like cervical cancer, there are countries that have managed to eradicate it completely because there's vaccines for these particular cancers. Okay. And also the earlier diagnosis, if the screening is done widely, the earlier diagnosis, there's better outcomes for treatment for these. So that's why there's actual need that there needs to have clear, robust investment by the government, both the national and the county governments, in the management of the cancer. Okay,
Dr. We'll talk about the commitment by the national and the counties, because there's need for also bringing on board the professionals who ought to be handling this, having break down the numbers in terms of those who are unemployed, yet they are graduates unregistered by the Kenya Medical Practitioners and Dentists Board Union. Honorable Patrick Munene, as the Vice Chairperson of the Health Committee of the National Assembly, we have identified the gaps they are in, and then certainly there is a pledge by the government as to how it plans to cover Kenyans universally when it comes to healthcare. How do we bridge? How is that bridge going to be between the gaps identified and the plan by the government?
Let me say this. Having looked at that report, I think as a country we can't say we are doing too badly in terms of cancer awareness, because as Dr. Ali is saying, initially maybe we had cases, but cases that were not known. But the fact that surveillance and screening has increased in the country now, we feel like we have more cases. So what I wish to say is that until cancer knocks at your door, you just think that those are just statistics. Like I was telling you yesterday. You know, I was telling you yesterday that if I known we are discussing cancer, I would not have come. Because I don't think I'm ill to discuss cancer. But I want to say this, that if cancer knocks at your door, it's poverty that has knocked your door in Kenya. Because treating cancer in this country is so expensive. And for many families, they can't afford, not even for many, even for those families that you think are able, treating cancer in this country is just impossible. So I want to say this. One, as Dr. Ali is saying, why don't we start with the known? Now that we know there are cancers that we can prevent, there are cancers that we can vaccinate people against, there are cancers that we can prevent through diet, why don't we start there before we start researching on those ones that we don't know the cause? So we had COVID here the other day, and we are still vaccinating people against COVID up to now. If we have a cancer that we have a vaccine against, why don't we give a vaccine to almost everybody? So what I want to say is that there's a government commitment towards cancer, but the amount of money, the amount of resources that is required is too much. I was reading yesterday that the number of oncologists we have in this country, leave alone the doctor, as you have said, oncologists. This country has less than 1,000 oncologists, the whole country. Less than 1,000 doctors who are supposed to treat cancer patients in this country. That's a big shortage of doctors in this country. And it becomes more complicated now with the two levels of government that we have. As we go to this debate, I would wish everybody to look at the complexity of the matter with the devolved government system. Because if we say we have 4,352 unemployed doctors, who should employ them in which hospital? The national government should employ some, the county government should employ some. When you push employment to county governments, most county governments feel employing a doctor is very expensive for them. So they will end up recruiting ECD teachers and a few nurses here and there. They'll tell you employing a doctor is very expensive. When a doctor went to specialize to become an oncologist, the county governments feel it's a waste of money because you have employed this person and you have financed them to go and learn. You find it's a major issue in the county governments. They don't want to release doctors to go and specialize and learn. So this has contributed to the shortage we are seeing of doctors today. But as I'm saying, we need to increase investment in the sector of health. We need to do more investment by the government because NHIF as it is today is not able to treat a cancer patient.
All right. Thank you so much, Mheshimiwa, for that opening remark. Now, joining us is Dr. Alfred Karagu from the National Cancer Institute. And thank you so much for coming. Earlier, before you joined us, we just went through the statistics and the numbers that are contained in a report that was released, just showing the status of cancer in the country. And I know that you are very pivotal in the crafting of that document. Just to rope you in on this, why should this document not be ignored? Why should it be treated with the importance that it deserves? What is it that it will help us do in managing the cancer crisis in the country?
Thank you, and good morning to our viewers. The status of cancer report, the annual status of cancer report that we released last week, was for us to start appreciating just how cancer as a disease affects us all as a country. You rightly said that previously we have done national estimates, but we must appreciate that as a country, our structure, our governance structure and our health delivery structure is actually a devolved structure, whereby we are looking at how best do we make investments, how best do we address emerging disease issues across the country. That's why we are very keen to begin documenting the distribution of cancer as a disease across the countries. And as a National Cancer Institute, one of our responsibilities is to maintain, we actually are required by law to ensure that accurate statistics of cancer as a disease are maintained in this country. And we have been doing that over the past 1.5 years. And so we put together data over a whole financial year, the year 2021-2022. So out of all the cancer cases that were reported to our database, one of the variables that is reported to us is the residence in which the person who is diagnosed lives. So that data is based on the data that we have triangulated across the residence in which these people live. So why is that important? This is important because it begins asking critical questions. For instance, if you are we were able to provide some estimates for about the top 5 cancers. So if you are saying that most of the cases that are being reported are coming from Nakuru County, for instance. For example, in cancer of the esophagus, we saw most of the reported cases coming from Kakamega. So now the next question is, why Kakamega? What are some of the issues that are probably in Kakamega that we need to think about in terms of risk exposure? So again, that also brings to the fore the need for to inform our investment efforts. For instance, we were talking about the issues of availability of human resource, availability of doctors, availability of experts who are trained in oncology. So if you are seeing a significant number of cases coming from, let's say, County X, then we ask ourselves, what is the commensurate investment in terms of human resource, in terms of infrastructure that is being done in those counties? So really that's why we put up that report. But other than just the numbers, we're also keen to highlight, one, our capability to conduct screening, because we realize that the bulk of our cancer cases actually are diagnosed in advanced stages. And yet, when you look at the profile of our cases, the top 5 cancers, which contribute to about 48% of our cases, most of them, actually almost all of them, can be screened and diagnosed early. So then we ask ourselves, what is our prevailing capacity across the country? So I think why we were keen on releasing this is for us to be able to progressively now look at what are we doing and what needs to be done to increase our capacity to be able to manage cancer as a country, yes. Okay.
Well, whilst you acknowledge that, Dr. that there certainly is the identification of these cases, and we had a breakdown of the number.
Yes.
But the human resource in terms of the investment in getting the specialists isn't commensurate. But we have been doing this report, for instance, the annual State of Cancer report in the past years as well. So why then are we not getting the right answers? Why are we not unlocking? What's the hurdle? What's the stumbling block towards the attainment of the specialists vis-a-vis the increasing cases so that they can be curbed? Because you have mentioned the problem and the problem where it is, and it's the specific counties, the prevalence amongst the segments of the population. However, there seems to be inadequate or a lacking commensurate of the human resource and the specialists they are in. So how can we bridge that?
I think it's for us to be able to appreciate that cancer care does not equate to having a cancer center. I think that's a beginning point. We have had a confusion between cancer centers and cancer services. You could provide cancer services in a typical hospital setting as long as you put in place the right mechanism. So I would feel that that realization needs to, probably that realization has not been there in the past. So maybe in terms of investment, in terms of, I don't want to apportion any blame, but in terms of thinking through what needs to be done, you've seen that most authorities, like for example, in most county governments, will be very quick to think about putting up a cancer center. And yet, what is required is to ensure that even within your existing environment, you have an enabling environment that can provide right care for cancer.
For example,
now ensuring that you have trained workforce. Okay. And the other thing that I would need also to put out there is we must not just think about oncologists, because cancer care is a holistic endeavor. You must have your doctors who are the oncologists, you must have your oncology nurses, you must have your pharmacists. So I think to answer your question, what needs to be done is to realize that I would say that in healthcare, there's the hardware and the software. Okay. So I think for a long time, we have focused probably more on the hardware. Right. Now we need to think about the software, ensuring that the workforce is there, the drugs are there, that kind of thing.
Thank you.
And I've seen the SecGen here, your body language, you understand where the shoe pinches in terms of even the welfare of the human resource in the health sector and where the problem could be. Because I remember from the numbers we've been taken through, seems like we have the people, but because of the environment, I don't know, is it like we don't have money to pay them? I don't know where the problem is, but we seem to be exporting human resource, yet in our very own country, we complain of lack of enough doctors and specialists to, address some of the diseases that are ailing us.
Thank you. I think one thing is the issue of the priority. As my brother said, clearly, I think this data now makes most of the governors and the leaders in the different counties understand the need to actually invest in healthcare. From the budget that was indicated, the health budget is 6%, which is way below the budget declaration. And this actually reflects the human resource from different counties. We have a data that shows that in around the whole country, about only 1,000 doctors have been employed in the last 5 years. These numbers that you're projecting is a span of 5 years. So it then translates that in every year, every county then employs only one doctor. That means you're going to have a majority of the doctors who have graduated who actually ought to be offering services and even screening and identifying and diagnosing these cases in the counties are outside, are not working. And that actually contributes to the high rise of the number of cases that we see. The other thing that is very evident is that we have some doctors who have gone abroad and even graduated as oncologists. Last year we had Dr. Hamid, who graduated in Alexandria, Egypt, and stayed for 1.5 years without employment. He had to actually advertise and write in Twitter and Facebook before he was employed to QTRH. So it means we actually have the personnel, we actually have quite a number of doctors who have graduated, and even nurses and clinical officers, who, if we have a priority to manage healthcare in the counties and the country, then we can actually boast and do a better service. But then the priority of the counties also comes in, the priority of the government. If the government does not invest or put money in healthcare, and then we put money in development, then we're going to have quite a number of, we call them white elephant projects, very many cropping facilities and level 4, level 5 hospitals, which actually don't be able to offer the services that are needed. And that's what we see across the country.
All right. Mheshimiwa, I'm curious to know, because as Kenyans, as common Kenyans, we speak through our vote, and it's you leaders who now take that up to the next level. You sit at the Health Committee at the National Assembly. What is in your entry? What are some of your priority areas as a committee? And we just want to know whether that matches with what we need to treat what is ailing our health sector.
Yes, I think I want to pick it from where Dr. Ali left, that we are a country that is so much fixated on structures, the structural buildings. If you allocate an hospital 1 billion today, or you allocate a county 1 billion today for health, the first priority that comes for them is a big building. Because I think there are benefits with the big buildings, so I don't understand. Because I've traveled across this world in benchmarking on all the matters. And as our president promised during his election, that what we need to prioritize is primary health care, preventive and promotive. Because if we say that 5% of the most prevalent cancers can be screened and detected early, I don't think to be detected, you need a doctor to detect that cancer. I think we just need to go home, to go to the village, to go to our doctors in the village. We need to go to our clinic officers in the village. We need to go to our nurses in the village. We need to train them how to screen and detect these cancers early. Because we can't concentrate on national level, building big hospitals, and we are not screening and realizing cancers early. You know, I normally tell people, having a level 5 or a level 6 or even a level 7 hospital is like having a very beautiful mortuary. You can construct a very beautiful mortuary, but we wish our people don't get there. We can have a very high level of hospital, but we wish our people don't get there. So why can't we detect these cancers early? So I think primary health care, I think going to the village and ensuring that we have good primary health care in the village will help us realize these cancers a bit early, because most cancers in Kenya today, as we get in the report, are detected at a very late stage. When people are completely sick is when they go to hospital. And furthermore, most Kenyans who die of cancer don't even know they died of cancer. Most people just die because, I was telling some people today when I was coming that when you get a cancer patient and you are told there is a kind of a cancer that occurs within a month that it kills somebody. So I realized when I was young, there are children who died, we are told they developed a headache and they died. So these were cancers also, and we didn't know. So many people in the village still don't know they are suffering from cancer. Okay. And as Dr. Ali was saying, we should not concentrate on, because right now with the National Cancer Institute, if you ask everybody what they should do, they will tell you they should build very big cancer institutes and very big cancer treatment centers. Why should you have these big cancer treatment centers for people to come to be treated for stage 4 cancers? Why couldn't we screen these cancers early enough? So I think primary health care is the solution to most of these. Yeah.
Okay, well noted. The place of primary health care in our model, the pathway to universal health care coverage as pledged by President William Ruto. And this, of course, kick-starting as pilot projects in the counties of Kisumu, Nyeri, and 2 other counties. And the spending in the 2022-2023 financial year, 146.8 billion, which is the 6% of the GDP, and by 9% below the required 15% as per the Abuja declaration, which was made in Nigeria. We are due for a break here on Daybreak, and the hashtag on Twitter is Daybreak. The SMS code is 22422. At Citizen TV Kenya, at Ayub Abdikadir, and at Safin_Acheng. After the break, we continue the discussion with Dr. Himji, Honorable Patrick Munene, and Dr. Karagu here on the broadcast. Stay tuned.